طيب بسم الله الرحمن الرحيم. Today our second part of this lecture overview of glomerular disease. In the previous part of the lecture we talked about clinical manifestations of glomerular injury and the differences between nephrotic and nephritic syndrome, the pathogenesis of glomerular disease and the different morphological types of glomerulonephritis. And we talked about the possible secondary causes of glomerular disease as well. In this lecture, we will try to discuss specific types of glomerulonephritis. First, we will start with minimal chain disease. Minimal chain disease always presents as nephrotic syndrome. Yani the type of clinical manifestation associated with minimal chain disease is always in form of nephrotic syndrome, as we discussed previously. In general, minimal chain disease represents around 75% of cases of nephrotic syndrome cases in children and 25% of nephrotic syndrome cases in adults. So it's a quite common disease. Whenever we talk about specific type of glomerulonephritis, we would like to know first if there are any associated secondary causes, and then we would like to know what the type of clinical manifestations which can develop in specific type of glomerulonephritis. And then we would like to talk about the renal biopsy findings, and finally, how to manage the condition. Regarding minimal chain disease, in most of the cases, it's an idiopathic condition. So it's a primary type of glomerulonephritis. As we discussed previously, glomerulonephritis in a lot of cases can be idiopathic in nature, and so it will be regarded as primary glomerulonephritis or primary glomerular disease. But there are situations in which you can detect some underlying cause, you can detect some secondary causes. In minimal chain disease, the condition is always idiopathic, but there are some associations, there are some secondary conditions which can be linked to minimal chain disease. For example, it's associated with certain types of malignancies like lymphoma and thymoma. Also, it's linked to specific drugs like rifampicin, for example, also lithium, also non-steroidal anti-inflammatory drugs. Also, it's associated with infectious mononucleosis. So these are associations of minimal chain disease, but in almost always, minimal chain disease is an idiopathic condition where you will not be able to detect any possible secondary cause. Clinically, minimal chain disease can present with proteinuria, subnephrotic range proteinuria. That means proteinuria less than 3 grams per day, or it can present with nephrotic syndrome, which means heavy proteinuria more than 3 grams per day. And proteinuria in minimal chain disease is always selective proteinuria. And that means you will have albuminuria specifically. So the proteins that are lost in the urine in minimal chain disease are mainly consisting of albumin. Because in the pathophysiology of minimal chain disease, as we discussed previously, T lymphocytes. There are some autoreactive T cells which will start releasing some cytokines, and these inflammatory cytokines in minimal chain disease will just neutralize the negative charge on the glomerular filtration membrane. It will reduce the negative charge on the glomerular filtration membrane, and so it will disrupt the charge barrier of the filtration membrane. It will not affect the size barrier. It will affect the charge barrier. And when the charge barrier is affected, as we discussed previously, albumin will start leaking because albumin has no problem with the size barrier. The size of albumin is enough to cross the size barrier, but the problem of albumin is with the charge barrier, because albumin is negatively charged and the glomerular filtration membrane is also negatively charged. So albumin normally will be repelled by the glomerular filtration membrane. But when there is minimal chain disease, due to disruption of the charge barrier, albumin will start leaking. So you will end up with selective proteinuria. You will have albuminuria, which can be heavy albuminuria leading to nephrotic syndrome. So this is the classical clinical presentation of minimal chain disease. But an important point also we should know whenever we talk about specific types of glomerulonephritis, we would like to know about the tendency of the disease to progress into chronic kidney disease and into end-stage renal disease. In minimal chain disease, the disease will not progress into chronic kidney disease. And it's always, in most of the cases, the disease is just limited to nephrotic syndrome or proteinuria, but it will not progress to result in chronic kidney disease. It's not one of the well-known causes of chronic kidney disease and end-stage renal disease. So this is the clinical presentation. Then let's talk about how to diagnose the condition. As we said previously, whenever you are dealing with glomerular disease, you get the clinical scenario, and according to that scenario, the first thing you will do, you will ask for urine analysis, where you find active urinary sediments like proteinuria, like microscopic hematuria, depending on the type of the disease. So in minimal change disease, when you do urine analysis, you will find that the patient is having proteinuria. When you quantify the urine per 24-hour, you check the collection of protein for 24 hours, you will find it in a lot of cases more than 3 grams per day. So it's nephrotic syndrome. But this is not enough in glomerular disease. You need to do renal biopsy in order to have an accurate diagnosis about the specific morphological type of glomerulonephritis, because in glomerular diseases, you need to know the morphological type you are dealing with. And according to that, you will know whether it could be idiopathic or there might be secondary causes, and then you will start looking for secondary causes in specific types of glomerulonephritis. So when you do renal biopsy in minimal change disease, the disease is called minimal change, and the name is indicating that you will have minimal changes under microscope when you do renal biopsy. When you do renal biopsy, first you will do light microscopic examination, as we discussed previously. In light microscopic examination, you would like to assess the thickness of the glomerular basement membrane and the degree of cellularity. In minimal change disease, the findings on light microscopy will be completely normal. You will have normal thickness of the glomerular basement membrane and you will have normal cellularity. The findings of minimal change disease are only detectable on electron microscope. On electron microscopic examination in minimal change disease, you will detect what is called effacement of the podocytes or fusion of the podocytes food processes. The food processes of the podocytes will start to fuse together, and this contributes to the leaking of albumin that happens in minimal change disease. As you can see here, this is the normal glomerular capillaries. As we discussed previously, the glomerular filtration membrane is made of 3 layers: endothelium, then basement membrane, and then from outside we have the podocytes, which form the visceral layer of the Bowman's capsule. These are the normal podocytes with normal food processes, and between these food processes we have what is called filtration slits. In minimal change disease, the first and the earliest change that will happen whenever there is any form of glomerular injury, whenever you have any glomerular injury, the earliest finding will be effacement or fusion of the podocytes. As you can see here, the food processes of the podocytes are no longer clearly seen because they are fused and effaced. And this is the only finding which will be detected in minimal change disease. It can be detected with other types of glomerulonephritis, but in other types of glomerulonephritis, you will have other findings as well, because this effacement of the podocytes indicate very early injury to the glomerulus. But in minimal change disease, this is the only finding which will be detected in order to put the diagnosis of minimal change disease. And that's why it's called minimal change disease. So this is the diagnostic finding in renal biopsy in patients with minimal change disease. As we said, minimal change disease is always idiopathic, so you will not do hard work in attempt to look for secondary causes. You will just consider the condition as a primary condition, as an idiopathic condition, and then you proceed to manage the patient. The good thing about minimal change disease, it has a good prognosis, because the majority of the cases, almost 80% of cases, are extremely steroid responsive. It responds very well to steroid therapy. And this is the specific treatment for minimal change disease. In general, when we talk about the management of any glomerular disease, there are 2 main elements. The first element is symptomatic treatment. Symptomatic treatment means the treatment of the clinical syndrome, whether it's nephrotic or nephritic syndrome, or if the patient is presenting with acute kidney injury, for example, or chronic kidney disease. This is symptomatic or supportive treatment. And then we have the specific treatment. The specific treatment is the treatment which is specifically directed towards the disease itself. And the specific treatment depends on whether the type of glomerular disease is primary or secondary. Are we dealing with idiopathic glomerular disease, or secondary glomerular disease, yani glomerular disease due to some underlying cause. If it's secondary, all you need to do is to treat the underlying cause. You need to treat the secondary cause. But if it's primary, there is no underlying cause to treat. So what you will do is you will control the immune system. You will try to suppress the immune system because glomerular injuries are always immune mediated. So if you cannot find secondary cause and you cannot treat secondary cause, you will control the immune system by giving immunosuppressive drugs like steroids. And in minimal chain disease, because the disease is always idiopathic, so you will start giving steroid therapy immediately. And the good thing, the disease is highly responsive to steroid. But before giving steroid, you have also to consider symptomatic treatment because these patients, they tend to present with nephrotic syndrome. So you have to address the complications of nephrotic syndrome. So how you will manage nephrotic syndrome in general, regardless of the cause of nephrotic syndrome, regardless of the type of glomerulonephritis. Whenever you have nephrotic syndrome, you are dealing, number one, with edema. The patient will have edema, and this edema might be generalized. It will be generalized edema. There might be even pleural effusion or ascites in some cases. So the first thing you need to address this edema. You have to control and to reduce the edema. Number two, you want to control the proteinuria, because this proteinuria, as long as the patient is losing proteins, the patient will have complications associated with nephrotic syndrome, and edema will be worsening, and you will have other complications. So you need to control this proteinuria. And then you need to control the complications of nephrotic syndrome, like infections and like thrombotic complications as well. So first of all, when we talk about the control of edema, how to control edema, before starting giving active treatment for edema in nephrotic syndrome, you need to evaluate always the volume state of the patient. You need to make sure this patient is fluid overloaded and not volume depleted, because yes, nephrotic syndrome is associated with fluid overload state and the patient is edematous, but there are cases in which nephrotic syndrome patients can present volume depleted. They can have actually hypovolemia, and they might need sometimes resuscitation with IV fluids. So it's important to evaluate the volume status of the patient and to make sure that the patient is not volume depleted, because volume depletion can kill the patient, can kill the patient faster. So after making sure that the patient is not volume depleted, and in order to control the edema, first of all, you have to put the patient on low salt diet. You have to restrict salt intake. Number two, you have to restrict water as well. So you need to consider water, salt and water restriction. This is the first step. And you need to give diuretics. The first line diuretic will be loop diuretics, furosemide. You can give up to sometimes 140 mg per day. While you are restricting salt and water and giving furosemide, you should measure the weight of the patient daily, and you should regularly evaluate the volume status of the patient. You should make sure that this patient is not undergoing volume depletion at any point, because restricting water and giving diuretics can easily precipitate volume depletion, and this volume depletion can actually precipitate acute kidney injury, because it will lead to prerenal azotemia, and it will lead to acute kidney injury. So it's very important when you are controlling edema to measure the weight of the patient daily and to assess and evaluate for any features of hypovolemia. So you need to evaluate the volume status. Your aim is you want to achieve 0.5 to 1 kg loss per day. You want to have a loss of 0.5 kilogram per day. In 2 days, you want the patient to lose 1 kilo. So if there are more losses of weight, then you have to consider your treatment. You have to reconsider your treatment. You have to reduce your diuretics, and you have to go easy on the water restriction. So this is the initial step in the management, control of edema. So to control edema, you need to restrict sodium and water, and you need to give diuretics. You start with furosemide. Then later on, if furosemide alone is not controlling the edema and the patient is still fluid overloaded, the next step, you can add thiazide diuretic. And when you add thiazide diuretic on top of furosemide, you will get a synergistic activity between the two types of diuretics, because furosemide will act proximally on the loop of Henle, and thiazide diuretic will act distally on the distal convoluted tubule. So combining the two types of diuretics together will give you best results. But you will not start from the beginning. You will start with just furosemide, and then later on you will add thiazide if furosemide alone is not controlling despite high doses. And again, you need to evaluate the volume status of the patient while you are giving diuretics. And along with that, also you need to assist the electrolytes, because furosemide and thiazide diuretics can lead to hypokalemia. Then the next step in the management of nephrotic syndrome, you need to control the proteinuria. How to control the proteinuria? First of all, IV albumin infusion has no role in the management of nephrotic syndrome. You cannot just replace the lost proteins in the urine by just giving IV albumin. This will not solve the problem. Actually, this can make the problem worse. It can lead to more proteinuria. When you give IV albumin infusion, this will lead to more proteinuria. So this is not an option to control proteinuria, not an option to replace the lost protein in the urine. To control proteinuria, you need to block the angiotensin II activity on the efferent arterioles of the kidney. So you need to give an ACE inhibitor or an angiotensin receptor blockers, because these drugs will block the action of angiotensin II at the level of the efferent arterioles. Here at this picture, the efferent arteriole here, it has receptors for angiotensin II, and when angiotensin II acts here on these receptors, normally it will lead to constriction of these efferent arterioles. And when these arterioles are constricted, as you can imagine, the blood normally flows from the afferent, enters the glomeruli, and then it leaves through the efferent. When you constrict the efferent arterioles, you will increase the pressure here, you will increase the blood flowing here. And when you increase the pressure within the glomerular capillaries, this immediately will increase the GFR. So if you are having a glomerular filtration membrane which is leaky in minimal chain disease, leaky to protein, when you increase the pressure here, this will lead to more proteinuria, because the increase in the GFR will push more protein into the filtrate. And so you will have more proteinuria. So angiotensin II is not doing anything good here in patients with nephrotic syndrome. Is actually worsening the proteinuria. So you need to block the action of angiotensin II here. By blocking the action of angiotensin II here, you will relax the efferent arteriole, it will become dilated, and this will allow the blood to flow, and it will reduce the pressure here. And when the pressure here is reduced, the glomerular filtration rate will reduce, and hence proteinuria will be reduced. So this is a strategy to control proteinuria in any patient with nephrotic syndrome. You give ACE inhibitor or angiotensin receptor blockers. So this is the next step, the second step. Controlling proteinuria is essential and vital, especially if you are dealing with a type of glomerulonephritis which has a tendency to progress into chronic kidney disease. With minimal chain disease, the condition has no tendency to progress to chronic kidney disease. But when you are talking about membranous glomerulonephritis, for example, or focused segmental, these types of glomerulonephritis can lead to chronic kidney disease. So the condition is chronic. So proteinuria will be chronic. And chronic proteinuria is very dangerous because proteinuria has pro-fibrotic effect. These proteins that are lost into the urine are not just associated with the features of nephrotic syndrome, but actually the losses of proteins into the urine with time, it can lead to fibrosis within the kidney. It leads to tubulo-interstitial scarring and fibrosis. And so it participates in the progression of chronic kidney disease. So controlling proteinuria is essential to reduce and to slow down the progression of chronic kidney disease. Then after controlling proteinuria, then you need also to control the complications that can result from nephrotic syndrome. For example, nephrotic syndrome, as we said, is associated with dyslipidemia. So you need to give statins to control the lipids. Also, as we said, nephrotic syndrome can lead to prothrombotic tendency. So it can lead to thromboembolic complications. So you give prophylaxis with low molecular weight heparin. You give low molecular weight heparin as prophylaxis to prevent the development of thrombotic complications in nephrotic syndrome. You give prophylactic dose, but if the patient developed a thromboembolic complication, then you will start giving therapeutic doses. And one of the important thrombotic complication with nephrotic syndrome is renal vein thrombosis. You might have a patient with nephrotic syndrome, and then suddenly this patient started to develop an acute flank pain, acute loin pain associated with gross hematuria. And there is also a worsening in the renal profile. The patient will go on to develop acute kidney injury. This is classical scenario of renal vein thrombosis, and it can be precipitated by nephrotic syndrome. So if you have a patient with nephrotic syndrome, it's unusual for patients with nephrotic syndrome to go on to develop acute kidney injury. Acute kidney injury is seen with nephritic syndrome. But if nephrotic syndrome has led to acute kidney injury, you should think that one possibility is that the patient has developed renal vein thrombosis due to hypercoagulable state. nephrotic syndrome, and this had led to acute kidney injury. This is one possibility. Another possibility might be the patient developed volume depletion, hypovolemia, could be due to the excessive diuretic uses iatrogenically, and this can lead to prerenal azotemia. This can also precipitate acute kidney injury. These are possible explanations for acute kidney injury in patients with nephrotic syndrome. So it's important to prevent the thrombotic complication by giving heparin prophylaxis. Then another complication also, as we said, nephrotic syndrome patients are prone to infections. There is immunosuppression due to losses of complement proteins and immunoglobulins into the urine with proteinuria. So you should consider to cover any possible infections. You will not give prophylactic antibiotics. It's not recommended. You will give antibiotics, antimicrobials in general, if you have a documented evidence of infection. If you are having an evidence of any infection, then at that point you will give antimicrobial treatment. But you will not give antibiotics or any antimicrobial treatment without any evidence of infection. So these are the highlights or the main elements in the management of nephrotic syndrome in general, and this should be considered as part of the symptomatic treatment in any patient presenting with nephrotic syndrome. Then the specific treatment in minimal change disease, as we said, the condition is idiopathic and it's highly responsive to steroids, so you will give steroid as specific treatment. And in some cases, the condition might not respond to steroid in rare cases. Under these circumstances, you can consider cyclophosphamide. So cyclophosphamide is considered only if the condition is considered steroid unresponsive. But steroid is the first line in the management of minimal change disease. In pediatrics age, if you have a case of nephrotic syndrome, you will assume immediately that the case is minimal change disease because this is the commonest cause of nephrotic syndrome in pediatrics overall. So you will give steroid immediately, even without doing renal biopsy. But in adults, always when you have nephrotic syndrome, you have to do renal biopsy first to know the exact type of glomerulonephritis, and after that, you can give steroids. This is another picture also to show the effacement of the podocytes. As you can see here, the food processes are nowhere to be found here. So let's talk about another type of glomerulonephritis, which is membranous glomerulonephritis. And this is an important cause of nephrotic syndrome in adults. Minimal change disease is an important cause of nephrotic syndrome in children, but membranous is an important cause of nephrotic syndrome in adults. It accounts for around 20 to 30% of adults' nephrotic syndromes cases. Clinically, before we talk about the clinical presentation, membranous glomerulonephritis can be idiopathic, it can be primary, but it has important secondary causes. It's one of the types of glomerulonephritis in which you can detect some underlying causes. So what are these secondary causes? We talked about it previously. It could be infection, it could be drugs, it could be malignancies, could be chronic diseases. Infections, for example, as we said previously, it could be hepatitis B, sometimes hepatitis C. It could be also some bacterial infections like subacute bacterial endocarditis or syphilis even. It could be some parasitic or protozoal infection like schistosomiasis or malaria, for example. So these are some of the infectious causes of membranous glomerulonephritis, and you should look for these possible causes. Also, it could be due to certain drugs, and there are drugs which can be secondary causes of membranous glomerulonephritis, like non-steroidal anti-inflammatory drugs, and also like the old anti-rheumatoid drugs like gold and penicillamine. Also, there might be heavy metal poisoning, also heavy metals which can precipitate membranous glomerulonephritis. Then we have malignancy also, which can include carcinomas, and it can include also hematological malignancies like lymphoma and myeloma, for example. And it could be also due to chronic systemic diseases, especially systemic lupus erythematosus. One of the stages of lupus nephritis is membranous glomerulonephritis. So SLE is one of the important systemic diseases associated with membranous glomerulonephritis. Also diabetes. Diabetes can give you membranous changes on biopsy. Amyloidosis. Amyloidosis is another important cause. Also, you can consider rheumatoid arthritis and other conditions. These are possible secondary causes of membranous glomerulonephritis. So membranous glomerulonephritis has a tendency to be secondary more than minimal change disease. Minimal change disease is always primary. So it's important to investigate patients with membranous glomerulonephritis for secondary causes. So the workup in membranous glomerulonephritis before the workup, clinically, these patients, they can present with proteinuria. It can be subnephrotic range proteinuria, or they can present with nephrotic syndrome, or they can present with chronic kidney disease. So this is one of the possible types of glomerulonephritis which can progress into chronic kidney disease. So it can be chronic condition. The proteinuria can persist, become chronic, and eventually it can lead to chronic kidney disease. So you can find the patient with membranous glomerulonephritis with any one of these presentations, either subnephrotic range proteinuria, or nephrotic syndrome, or chronic kidney disease. On biopsy, when you do light microscopic examination in membranous glomerulonephritis, you will have an increased thickness of the glomerular basement membrane. And this is different than minimal chain disease. So the thickness of the glomerular basement membrane will be increased, and that's why it's called membranous. Whenever you see the term membranous, it indicates that this type of glomerulonephritis is associated with increased thickness of the glomerular basement membrane. But the cellularity is normal. There is no hypercellularity. So increased thickness of the glomerular basement membrane with normal cellularity on light microscopic examination. On electron microscopic examination, remember, as we said in the previous lecture, electron microscopy will help you to detect the immunological deposits, because these are electron dense immunological deposits. You will detect these immunological deposits, and you will know the site of the immunological deposits on the glomerular filtration membrane. In membranous glomerulonephritis, you will have electron dense immunological deposits located along the subepithelial surface of the glomerular filtration membrane. So you will have subepithelial electron dense deposits. Remember, we said that there are three layers of the glomerular filtration membrane. The inner layer is the endothelium. Then we have the basement membrane, and then outside we have the podocyte. When we say we have subepithelial deposits means that the immunological deposits are located underneath the epithelial layer, which is the podocytes layer. So underneath the podocyte, you will have the subepithelial surface, and at that site, you will have the immunological deposits associated with membranous glomerulonephritis. So in membranous glomerulonephritis, you will have subepithelial immunological deposits, and it will give you characteristic appearance called spike and dome appearance. As you can see here, this is the normal glomerulus, but this is patient with membranous glomerulonephritis. First, as you can see, the glomerular basement membrane is thicker compared to the normal picture, and there are immunological deposits in the subepithelial surface. And these immunological deposits, as you can see, there are parts, there are some gaps between the deposits. These immunological deposits, along with the gaps between the deposits, give you the characteristic appearance called spike and dome appearance. The dome is the deposit, and the spike is the gap between the deposits. It's called spike and dome appearance. And this is characteristic for membranous glomerulonephritis. This is on electron microscopic examination. Then, as we said previously, the third test you will do on renal biopsy is immunofluorescence study. In immunofluorescence studies, you will know the exact components, the immunological components of these immunological deposits. You will know what are the contents of these deposits, whether there are immunoglobulins, whether there are complements, and what types of immunoglobulins and what type of complements. In membranous glomerulonephritis, you will have these immunological deposits are consisting of IgG and C3. So you have IgG and C3 deposits, and this will be seen on immunofluorescence studies. So these are the findings in membranous glomerulonephritis to put the diagnosis of membranous. So the next step, how to manage the condition. As we said previously, first, symptomatic treatment. If the patient is presenting with nephrotic syndrome or chronic kidney disease, you will give treatment symptomatically, as we said previously. Specific treatment depends whether this is idiopathic or secondary. So before saying idiopathic membranous glomerulonephritis, you need to exclude important secondary causes. So you need to do a lot of workup, starting from the history, going to clinical examination, and then investigations. For example, classical scenario, in the exams, they will give you a smoker patient present with a history of hemoptysis, or they might not give you history of hemoptysis, and then the patient starts to develop proteinuria or nephrotic syndrome. And this might be membranous glomerulonephritis secondary to lung cancer, for example. Or there might be history of certain drug associated with membranous glomerulonephritis, or there might be infective endocarditis, which has led to membranous glomerulonephritis, or malaria, associated with membranous glomerulonephritis. So you need to exclude secondary causes. And if you detect any secondary cause, the specific treatment is just by treating the secondary cause. But if you could not detect any secondary cause and you consider the condition as idiopathic primary, so at that point you will control the immune system by giving immunosuppressive therapy. But membranous glomerulonephritis, unfortunately, is poorly responsive to steroid therapy alone. So in general, in the management and specific treatment of membranous glomerulonephritis, we give a combination of steroid with another agent like cyclophosphamide or chlorambucil. So usually you give a combination of two immunosuppressive drugs, corticosteroid plus cyclophosphamide or chlorambucil in the management of membranous glomerulonephritis. Its prognosis in membranous glomerulonephritis is worse compared to minimal change disease because the disease has a tendency to go on into chronic kidney disease. It's characterized by a rule of third of cases, third of lucky patients will undergo spontaneous remission, while third of the patient will remain proteinuric. They can have some low-grade proteinuria. It might not be clinically significant, but it will be chronic, and eventually this chronic proteinuria might lead to chronic kidney disease. As we said previously, proteinuria has a pro-fibrotic tendency, and it can accelerate the progression of chronic kidney disease. So 1/3 of the patient can remain proteinuric, and unfortunately 1/3 of the patient will eventually develop end-stage renal disease. This is the rule of third in membranous glomerulonephritis. Third of the patient will undergo spontaneous remission. These are the lucky patients. Third will remain proteinuric, and third will go eventually to develop end-stage renal disease. Is my voice clear, Jamar?
Yes.
Clear, Dr. Khalid.
Okay. So the third type of glomerulonephritis is focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis again can be idiopathic or it can be secondary. First, before we talk about the causes, let's see from where the name is coming. Focal segmental glomerulosclerosis. Sclerosis means fibrosis, as we said previously. Nephrologists, they use sclerosis to indicate fibrosis or scarring. So when you have glomerulosclerosis, that means these patients will have scarring of the glomeruli. So from the name, you can immediately understand that these patients are very likely to develop chronic kidney disease because there is scarring of the kidney. So you have glomerular scarring, but this glomerular scarring tend to be focal and segmental. Focal means that less than 50% of the total glomeruli are affected. This is different than diffuse. You compare focal to diffuse. When you use the term focal, that means on the examined specimen, you have less than 50% of the glomeruli affected. But if you have the term diffuse, it means that more than 50%, the majority of the glomeruli are affected. Segmental means that there are parts of the affected glomerulus affected. There are parts of the affected glomerulus showing the active disease. When you examine a single glomerulus tuft, you will have patchy involvement of the glomerulus, segmental involvement. There are some parts of the affected glomerulus will be spared. And segmental is compared to global. When you have global glomerular disease, that means the whole circumference and the whole glomerulus tuft is affected. But segmental means that only parts of the glomerular tuft is affected. So not all the glomeruli are affected. And in the affected glomerulus, not part of the glomerulus will be affected. So this is what means by focal segmental glomerulosclerosis. The condition can be either idiopathic without underlying cause, or it could be secondary. The classical secondary causes, especially for MRCP, HIV and IV drug abusers, especially heroin drug abusers. But actually, practically speaking, focal segmental glomerulosclerosis can be seen with any condition which lead to loss of nephrons in the kidney. So any disorder that affects the kidney and it leads to losses of nephrons within the kidney, this can eventually give you focal segmental glomerulosclerosis changes on biopsy. For example, the classical example is reflux nephropathy. Patients with reflux nephropathy, those patients who are having, for example, vesico-ureteric orifice dysfunction. Those patients are prone to develop recurrent attacks of urinary tract infection, ascending infections. Any patients with obstructive uropathy, They can have recurrent ascending urinary tract infections. And these recurrent urinary tract infections on the kidney, eventually it can lead to scarring within the kidney. It can lead to damage to the nephrons. So you will have losses of nephrons within the kidney with time. As the time goes by, you will lose a lot of nephrons from the kidney. Also, in patients with sickle cell nephropathy, or patients who are having renal agenesis for any reason, maybe congenital, there is agenesis of one kidney. When there is any condition associated with any losses of nephrons, even if you have other types of chronic glomerulonephritis, and other than focused segmental glomerulosclerosis, for example, you have membranoproliferative. With any chronic type of glomerulonephritis, you will lose nephrons with time. So any condition associated with chronic losses of nephrons can eventually precipitate focused segmental glomerulosclerosis, because when you lose nephrons, the rest of the healthy nephrons will start to compensate. It will undergo hypertrophy. You will have glomerular hypertrophy of the healthy nephrons in order to compensate for the lost nephrons. And whenever there is glomerular hypertrophy, you will have glomerular hyperfiltration. When the glomerulus become hypertrophied, the blood flow in the glomerulus logically will increase. And this increase in the blood flow in the glomerulus will increase the glomerular pressure, and it will cause glomerular hypertension. And this glomerular hypertension will lead to glomerular hyperfiltration. This glomerular hypertension and glomerular hyperfiltration actually is dangerous on the kidney on the long run. And initially, it's compensatory. It compensates for the lost nephrons. But with time, imagine if the nephron is exposed to high pressure on a regular basis. This high pressure within each nephron, within each glomerulus, will put stress on the wall of the glomerulus. It will increase the wall stress, and it will lead to endothelial injury. It will injure the endothelial layer of the glomerular wall. And this eventually, with time, will lead to scarring. And this can give you eventually focused segmental glomerulosclerosis, because not all the nephrons are undergoing hypertrophy. Not all the glomeruli are hypertrophied. There are some lost nephrons, and some of them are undergoing compensatory hypertrophy. So you will have patchy disease, and it will be similar to focused segmental glomerulosclerosis. So my point is, focused segmental glomerulosclerosis is a quite common biopsy finding, actually, because any form of chronic disease affecting the kidney, leading to continuous losses of nephrons from the kidney, it eventually can lead to glomerulosclerosis, and it can lead to focused segmental glomerulosclerosis specifically. And for that reason, for example, patients with IgA nephropathy, and I'll tell later on about the classical findings on IgA nephropathy, but sometimes IgA nephropathy on biopsy can give you some focal segmental glomerulosclerosis changes. This is not directly related to IgA nephropathy, but it's related to the chronicity of IgA nephropathy that had led to loss of nephrons from the kidney, and eventually it had led to focused segmental glomerulosclerosis. I hope this point is clear. There are some cases of COVID-19 which also has been linked to focused segmental glomerulosclerosis. There are some unfortunate patients during the pandemic presented with renal manifestations, with glomerular injury, and eventually on biopsy it was found to be similar to the changes of HIV on the kidney. So it will be focused segmental glomerulosclerosis. Specifically, we call it collapsing glomerulonephritis. This is a specific variant of focused segmental glomerulosclerosis in HIV and also with COVID-19 seen. So the classical secondary causes are HIV and IV drug abusers, but again, this condition can be seen with any disorder associated with loss of nephrons and loss of glomeruli from the kidneys. So any chronic glomerulonephritis can eventually be accompanied by focal segmental glomerulosclerosis. A significant number of patients with focused segmental glomerulonephritis or glomerulosclerosis go on to develop end-stage renal disease. Actually, around almost 50%. This is another important point. Almost 50% of patients diagnosed with focused segmental glomerulosclerosis after transplantation, they present with the recurrent disease. So 50% of cases of focal segmental tend to recur after transplantation. So this is an important cause of rejection, an important cause of dysfunction of the transplanted kidney, recurrence of the underlying condition, original underlying condition, and focused segmental glomerulosclerosis in 30 to 50% of cases has a tendency to relapse and to recur after transplantation. But still, this is not the most common type of glomerulonephritis which recur after transplantation. The commonest one to recur after transplantation is membranoproliferative, and specifically type 2, membranoproliferative type 2 glomerulonephritis. So the clinical presentation, yani, as you can understand, yani, this is a chronic condition which leads to sclerosis in the kidney. So if you are dealing with chronic glomerulonephritis, that means classically the patient will present with proteinuria or nephrotic syndrome, or eventually with chronic kidney disease. And the progression can be in this manner. Yani it can start as subnephrotic range proteinuria, and then it progresses into nephrotic syndrome, and then it can lead to chronic kidney disease. Or the patient might be having chronic subnephrotic range proteinuria, which is not diagnosed for many years, and eventually the patient will present with chronic kidney disease. So it's a proteinuric yani, type of glomerulonephritis. The biopsy finding, as we discussed previously, yani, in glomerulosclerosis, it involves a minority of the glomeruli focal, less than 50%, and only a portion of the glomerular globe, yani, it will be segmented. Approximately 50%, as we said. When we talk about the treatment in focused segmental glomerulosclerosis, again, the prognosis here is poor when you compare it to minimal change disease, for example. 50% of patients actually do not respond to steroid therapy. So what you will do is, يعني, you have to control طبعا proteinuria with ACE inhibitor, and if there is nephrotic syndrome, you have to consider symptomatic treatment for nephrotic syndrome. But specific treatment, if there is secondary cause like HIV, you will address the secondary cause. You give antiretroviral drugs. But if you cannot detect secondary cause and the condition is considered idiopathic, you will give a trial of steroid. But unfortunately, 50% are non-responder to steroids, non-responders. In those patients who are not responding to steroids, the second line is calcineurin inhibitors. You can use a calcineurin inhibitor drug. Calcineurin inhibitor drug like cyclosporin and like tacrolimus. These are the drugs used as an anti-rejection drugs post-renal transplantation. So calcineurin inhibitor like cyclosporin or tacrolimus are considered in cases of focused segmental glomerulosclerosis resistant to steroid therapy. Also, يعني, it was mentioned that in patients who are having focused segmental glomerulosclerosis after transplantation, there is a rule for plasma exchange, plasmapheresis. So plasma exchange, it can be considered, according to the literature, after transplantation, if the patient developed يعني, recurrent focused segmental glomerulosclerosis after transplantation. You might ask you, يعني, in addition to steroid and calcineurin inhibitor, what else you can give? In these patients specifically, you can consider plasma exchange. It tend to be effective in those patients. So that's all about focused segmental glomerulosclerosis. Now let's talk about membranoproliferative glomerulonephritis, which is also called mesangiocapillary glomerulonephritis. This is another term. This is a bit complicated type of glomerulonephritis. It has two types, two subtypes, type 1 and type 2. Type 1 is also called immune complex associated membranoproliferative glomerulonephritis, while type 2 is called C3 glomerulopathy. Type 1 is the dominant type. It accounts for 90% of cases. And type 1 is classically associated with cryoglobulinemia and hepatitis C virus infection. So these are the secondary causes for this type of glomerulonephritis. And these are very important causes and classical exam scenario. So clinically, in general, membranoproliferative glomerulonephritis has a tendency to progress into chronic kidney disease, an important cause of chronic kidney disease. It can present with proteinuria, can present with nephrotic syndrome, it can present with chronic kidney disease, and there are some cases in which membranoproliferative glomerulonephritis can give you mixed nephrotic syndrome. This is one of the examples of the types of glomerulonephritis which give you mixed picture of nephrotic syndrome. Another type also which give you mixed nephrotic is diffuse proliferative glomerulonephritis. We will talk about it later on. But remember, membranoproliferative glomerulonephritis can give you mixed nephrotic syndrome. The previous types that we discussed, minimal change disease, focused segmental and membranous, these are not associated with any nephritic element. The previous types are only associated with nephrotic and chronic kidney disease, nephrotic syndrome and proteinuria. But here, you can have proteinuria only, nephrotic syndrome, or you can have mixed nephrotic. And this can be applied to both type 1 and type 2. So let's talk about the findings on biopsy in type 1. In type 1, you will have subendothelial and mesangial immune deposits. So the deposits here, which will be detected on electron microscope, it will be in the subendothelial surface and on the mesangium. This is very important in order to differentiate it from the deposits in the second type. But before the deposits, on light microscopic examination in membranoproliferative, you will have increase in the thickness of glomerular basement membrane, similar to membranous, but the difference between membranoproliferative and membranous is in the cellularity. The cellularity here will be increased. You will have hypercellularity. And this is how to differentiate membranoproliferative from membranous on light microscopic examination. On immunofluorescence assessment, you will detect immunological deposits. As we said, these immunological deposits will consist of immunoglobulins, which can be IgG, along with complement proteins, which is specifically C4 in case of type 1 membranoproliferative glomerulonephritis. And these patients will have low serum C4 level. You will have hypocomplementemia, specifically low C4. And these findings are very important to compare it with type 2, as we will talk here. In type 2, which is also called C3 glomerulopathy, this is a rare type of glomerulonephritis, but it's a bit complicated because the pathophysiology here is still not well understood. This type of glomerulonephritis is associated with genetic or acquired defect in the alternative complement pathway. The classical example, you have something called C3 nephritic factor. C3 nephritic factor is basically an autoantibody. So it's basically can be an autoimmune disease. This is an autoantibody called C3 nephritic factor. This autoantibody will bind to an important protein, an important enzyme called C3 convertase. C3 convertase is an enzyme which is essential in the alternative complement pathway. It activates the C3 complement. What happens is this C3 nephritic factor in certain individuals, they have C3 nephritic factor in their blood, and this C3 nephritic factor will bind to C3 convertase enzyme, and it will prevent the breakdown of C3 convertase. It will prevent the breakdown of C3 convertase. And so that means, in an indirect way, it will enhance the activity of C3 convertase. And when the activity of C3 convertase is enhanced, it will activate the alternative complement pathway in an excessive fashion. So in these patients, you will have excessive activation of the alternative complement pathway. And for some reason, this activation of the alternative complement pathway will be directed towards the glomeruli of the kidney. And so the patient will present mainly with the glomerular disease. And this glomerular disease is mediated by complements, and specifically mediated by C3 complement. And it's due to activation of the alternative complement pathway. And this type of glomerulonephritis, an interesting fact about this type, when you do microscopic examination under electron microscope, and when you do immunofluorescence, you will find the immunological deposits to be intramembranous, not subendothelial and mesangial as in the first type. Here, it will be within the membrane, within the glomerular basement membrane. But the interesting fact is on immunofluorescence tests. In immunofluorescence studies, you will be able to detect C3 proteins, but without any immunoglobulin. You will have only complements depositing without any evidence of immunoglobulin. And this is how to differentiate this type from any other type of glomerulonephritis. Always in different types of glomerulonephritis, there is an element of immunoglobulins within the immunological deposits. But here, you will have complements without immunoglobulins. And this tells you the pathophysiology, the importance of the complements in the pathogenesis of this type of glomerulonephritis. So the complements are mediating the injury here without immunoglobulins. So to differentiate on biopsy between these two types, in the first type, you have subendothelial and mesangial deposits, which consisting of immunoglobulins and complements. But here you have intramembranous immunological deposits consisting only of C3, but without immunoglobulins. Also, this condition is associated with partial lipodystrophy, in which there is loss of subcutaneous fat from the face specifically. That's why it's called partial lipodystrophy. This is classically linked with this type of glomerulonephritis. And here you will have, of course, since C3 is consumed in the pathogenesis, C3 are consumed here in the pathology. For that reason, C3 level will drop in the blood. So you have low C3. This is another way to differentiate between the two types. In the first type, you have low C4. But in the second type, you have low C3. That's why this condition is called C3 glomerulopathy, because it's a glomerular disease mediated by C3 complement specifically. So the management of this condition is actually very difficult. This might be one of the hardest types of glomerulonephritis to control and to treat. you will control the symptoms. You will provide symptomatic treatment for proteinuria and for nephrotic syndrome and for chronic kidney disease. For example, the patient might be dependent on dialysis by the time of diagnosis. Regarding the specific treatment, if there is a secondary cause like hepatitis C or cryoglobulinemia, you give a specific treatment for secondary causes. But the problem is in primary cases of membranoproliferative glomerulonephritis, you need to give immunosuppressive therapy, and unfortunately, a lot of cases are resistant to immunosuppressive therapy. But you will do your best. You will give a combination of steroid with another immunosuppressive drug like cyclophosphamide, for example, similar to membranous glomerulonephritis. But the results are not as promising as membranous glomerulonephritis. So these are points related to membranoproliferative glomerulonephritis. There is one point I forgot to mention, previously in membranous glomerulonephritis. In the idiopathic type of membranous glomerulonephritis, in 80% of cases, it's associated with a special type of antibody called antiphospholipase A2 receptor antibodies. Antiphospholipase A2 receptor antibodies. These antibodies are detected in up to 80% of cases of idiopathic membranous glomerulonephritis. So, one way to know this condition is idiopathic is to look for these antibodies. You check the antiphospholipase A2 receptor antibodies, which can be positive in a significant number of idiopathic cases of membranous glomerulonephritis, but it will not be detected with the secondary cases of membranous glomerulonephritis. So now let's talk about diffuse proliferative glomerulonephritis. And at that point, we will start talking about the types of glomerulonephritis which has a tendency to present with acute manifestations. So that means they can lead to acute kidney injury. They can present as nephritic syndrome and can progress to acute kidney injury. In the previous types, we talked mainly about proteinuric types of glomerulonephritis, which has a tendency to lead to chronic kidney disease. But now we'll start talking about some of the types of glomerulonephritis which can lead to acute manifestations with nephritic syndrome and even eventually with acute kidney injury. So diffuse proliferative glomerulonephritis, this morphological type is classically seen with post-streptococcal glomerulonephritis. This is the classical secondary cause of diffuse proliferative glomerulonephritis following a streptococcal infection. But also this morphological type of glomerulonephritis can be seen with systemic lupus erythematosus. It's one of the types of lupus nephritis, and it's actually the commonest histological type of lupus nephritis. So when you talk about diffuse proliferative glomerulonephritis, think about post-streptococcal glomerulonephritis and think about lupus nephritis. In post-streptococcal glomerulonephritis, as we discussed previously in the pathogenesis of glomerular diseases, we mentioned that it might be due to circulating immune complexes, type 3 hypersensitivity reaction. There might be a free antigen in the blood, which binds to antibodies, forming immune complexes in the circulation. And then these immune complexes will get trapped within the glomerular wall, and it will trigger complement-mediated inflammation of the glomerular wall. It will lead to necrotizing vasculitis. And this is what happens in post-streptococcal glomerulonephritis. So here you have circulating immune complexes, which made of streptococcal antigens. And the streptococcal infection will precede the onset of glomerulonephritis by weeks. So the condition usually develops 1 to 2 weeks, 7 to 14 days, and 1 to 2 weeks following an infection with the streptococcus, specifically with beta hemolytic streptococcal infection. And this infection can be affecting the upper respiratory tract in most of the cases, or it can be even in the skin. It might be streptococcal skin infection. So following a streptococcal infection, after 1 to 2 weeks, sometimes up to 6 weeks, actually, following the streptococcal infection, the patient will develop a type of glomerulonephritis, which is called diffuse proliferative glomerulonephritis, detected on biopsy. And in this type of glomerulonephritis, clinically, the patient will present with acute presentation. Acute presentation means initially there might be microscopic hematuria only. But as the disease progresses, this microscopic hematuria will convert into full nephritic syndrome. And previously, we talked about the features of nephritic syndrome, in which you will have microscopic hematuria with dysmorphic red blood cells, with red blood cells cast, with azotemia, oliguria, and hypertension. These are the features of nephritic syndrome, and it can be the presenting feature in diffuse proliferative glomerulonephritis. And unfortunately, eventually, this type of glomerulonephritis can convert into another type of glomerulonephritis, which is rapidly progressive glomerulonephritis. And when it converts into rapidly progressive glomerulonephritis, at that point, the patient will present with acute kidney injury. So diffuse proliferative glomerulonephritis can lead to acute kidney injury. And for that reason, this can be a serious condition. It's an important point also to know, it's not always post-streptococcal. It's actually, in some cases, it's called post-infectious glomerulonephritis, not necessarily streptococcal. Sometimes there are other types of bacterial infection or even non-bacterial infection, which can give you similar morphological type of glomerulonephritis. For example, it can be diffuse proliferative glomerulonephritis due to post-staphylococcal infection. Staphylococcal, not streptococcal. But the classical infection is a streptococcal infection. And commonly, it's seen in young children. This disease is commonly in young children and not seen usually in elderly patients. So on biopsy, in diffuse proliferative glomerulonephritis, as the name implies, it's a diffuse and proliferative type of glomerulonephritis. As we said previously, when you have a type of glomerulonephritis presenting with acute manifestations like nephritic syndrome and acute kidney injury, you will expect to have hypercellularity. You will expect to have biopsy to show you heavy cellularity with proliferation of the local cells and with infiltration by neutrophils and other inflammatory cells. So this is what happens here in this type of glomerulonephritis. You have diffuse disease affecting the majority of the glomeruli, unlike the focal segmental, and it's proliferative. So there is hypercellularity. You will have an increased cellularity coming from the proliferation of the local cells, endothelial cells, mesangial cells, and epithelial cells, along with infiltration of neutrophils and other inflammatory cells. So you will have a heavy inflammatory environment within the glomerulus in case of diffuse proliferative glomerulonephritis. And the immune complexes here are classically seen in the subepithelial surface, so underneath the podocytes. And it will give you something characteristic called subepithelial humps. This indicates the immune deposits, which are consisting of IgG, IgM, and C3 in case of diffuse proliferative glomerulonephritis. The management of this condition, unfortunately, there is no specific treatment for diffuse proliferative glomerulonephritis. Before, when you are putting the diagnosis of diffuse proliferative glomerulonephritis, you need to look for evidence of streptococcal infection. You will check the ASO titer, the streptolysin O titer. You can check the anti-DNase level to look for the evidence of streptococcal infection. And also, here the inflammation is heavy, as you said. So there is a heavy consumption of C3 proteins. And you will have low C3 level. This is one of the types of glomerulonephritis which will give you low C3. Similar to membranoproliferative type 2. As you can see here, there is low C3. There is a group of glomerulonephritis associated with low C3, with hypocomplementemia. Number one is post-streptococcal glomerulonephritis. Number two is SLE, and both are associated with diffuse proliferative. In both conditions, you will have heavy consumption of C3 proteins, and so it will be depleted in the blood. Another also condition associated with depletion of complement proteins and glomerulonephritis at the same time is infective endocarditis specifically. And also in the second type of membranoproliferative glomerulonephritis. So remember these possible conditions in which there is consumption of C3 proteins. Diffuse proliferative glomerulonephritis could be post-streptococcal or SLE, infective endocarditis, and type 2 membranoproliferative glomerulonephritis as well. Type 1 is associated with low C4, not low C3. So the specific treatment here, the management in general, as we said, first of all, symptomatic. And the symptomatic treatment in diffuse proliferative glomerulonephritis is the management of nephritic syndrome. The management of nephritic syndrome in general is mainly based on controlling the blood pressure, controlling the hypertension, because the main problem in nephritic syndrome is hypertension, because this hypertension will worsen the renal function. And so it's important to control this high blood pressure. So along with that also, nephritic syndrome, as we said previously, can also be associated with fluid overload and edema because there is oliguria. So there is tendency for fluid overload and edema. So again, you restrict salt and water, similar to nephrotic syndrome, and you give diuretics as well, while carefully monitoring the volume status of the patient. And to control hypertension, here you will give antihypertensive drugs, but you will try to avoid ACE inhibitor and ARB. This is very important. In nephrotic syndrome, we use ACE inhibitor and ARB to control proteinuria, and it has prognostic benefit in chronic kidney disease. Controlling proteinuria will slow the progression of chronic kidney disease. But in nephrotic syndrome, the scenario is different. Here, you need to avoid ACE inhibitor and ARB. First, there is no proteinuria here to begin with. There's no significant proteinuria. Number two, it can be even dangerous in these patients. It can be nephrotoxic. ACE inhibitors and ARB are very strange drugs. They are paradoxical drugs. They are beneficial and has prognostic benefit, and they improve the outcome in chronic kidney diseases, especially in proteinuric chronic kidney disease. But when you are dealing with a renal disease with risk of acute kidney injury or any comorbidity which can put the patient at risk of acute kidney injury, in these patients, ACE inhibitor will be nephrotoxic. For example, if you have a patient with gastroenteritis and losing a lot of fluids, in these patients, if the patient is already using ACE inhibitor, it's wise to stop the drug temporarily, because these patients with severe gastroenteritis, since if they are using ACE inhibitor, it can precipitate acute kidney injury, because the drug nephrotoxic in acute settings. Because in acute settings, the renin-angiotensin-aldosterone system actually is very important in maintaining the renal perfusion and maintaining the GFR, because if the angiotensin 2, as we discussed previously, act on the efferent arteriole here, it constricts the efferent arteriole. By constricting the efferent arteriole, it will increase the pressure here within the glomerulus, and this will improve the GFR. So if you're having a condition which associated with reduction in the GFR, like in nephrotic syndrome, or in patient who is losing fluid, patient who is volume depleted, ACE inhibitor will block the action of angiotensin 2 here. And this will reduce the GFR here, because when you block angiotensin 2 action here, you will dilate the efferent arterioles, you will reduce the pressure here, and you will reduce the glomerular filtration rate. So you can understand in patients who are having burns, patients with severe gastroenteritis, patients with severe vomiting, patients with diabetic ketoacidosis, for example, or patients who are having nephrotic syndrome in which there is oliguria, blocking the effect of angiotensin 2 here can be dangerous to the kidney. It will be nephrotoxic, because you will reduce the GFR further and will reduce the ability of the kidney to eliminate waste products and to regulate water balance. And so you will have more water overload, more fluid overload, and more metabolic waste products toxicity in the blood. For that reason, in nephrotic syndrome, it's wise to avoid ACE inhibitors and ARB to control the blood pressure. If you want to control the hypertension in these patients, you can use calcium channel blockers. You can use beta blockers as well. They play a very good role, especially beta blockers are effective in patients with glomerular disease, and calcium channel blocker as well, but not ACE inhibitor in patients with nephrotic syndrome. So this is just a practical tip. From now on, if you have any patients at risk of volume depletion, not necessarily to have volume depletion, if just there is a risk for volume depletion, you should stop the ACE inhibitors and AR temporarily until the patient is recovering from the illness, recovering from gastroenteritis, recovering from vomiting, from any cause, recovering from anything, which can put the patient at risk of AKI. Because these drugs are nephrotoxic in acute settings, and they are renoprotective actually in chronic kidney disease. It's a paradoxical group of drugs, but it's important to know when to use these drugs and when to stop these drugs and when not to use it from the beginning. I hope this point clear regarding nephrotic syndrome management and the use of ACE inhibitors specifically. Then after that, in nephrotic syndrome, you consider renal replacement therapy, dialysis, as indicated, as the standard indications, because nephrotic syndrome can easily progress to acute kidney injury. So as part of the supportive or symptomatic treatment, you can consider dialysis if there is any indication. For example, there is hyperkalemia refractory to medical treatment. Unfortunately, in this type of glomerulonephritis, there is no specific treatment. Steroids will not help the patient. So the good thing about post-streptococcal glomerulonephritis, in most of the cases, it tends to resolve spontaneously. So all you will do is you support the patient during the illness until the patient recovers spontaneously. This is the good thing about post-streptococcal glomerulonephritis. But you will not give specific treatment to address the disease. You will not give immunosuppressive drugs. This is the histological appearance of patient with diffuse proliferative glomerulonephritis. As you can see, there is an overcrowded environment with hypercellularity. There are infiltration recruited neutrophils, as you can see. These are all neutrophils recruited to the glomeruli, and it's overcrowding the area, as you can see here, and the disease is diffuse, affecting the whole, affecting the majority of the glomeruli. And from this heavy inflammatory environment, you can tell this patient will present with acute presentation. This patient will not present with chronic kidney disease. This patient will present with nephritic syndrome, and it can progress into acute kidney injury. It can convert into rapidly progressive glomerulonephritis. There are some cases of diffuse proliferative glomerulonephritis, which can present also with mixed nephritic, nephrotic. But nephritic picture is the dominant. And this is also another, when you talk about the types of glomerulonephritis, which can give you mixed nephritic, nephrotic, the first one you should think about is membranoproliferative. The second one, you can consider diffuse proliferative glomerulonephritis. Next, let's talk about important disease, which is IgA nephropathy. IgA nephropathy actually is the commonest cause of glomerulonephritis worldwide. This is an important condition. It's a common condition, and a lot of patients, especially those who are presenting with secondary hypertension, young patients with secondary hypertension unexplained, eventually, when you do renal biopsy as part of the workup, unfortunately, you will detect that the patient is having IgA nephropathy as a cause of secondary hypertension. So this is a common disease nowadays. The condition is idiopathic, usually, but there are some associations. It's classically associated with Henoch-Schönlein purpura. Henoch-Schönlein purpura, actually, IgA nephropathy sometimes can be considered as the renal manifestation of Henoch-Schönlein purpura. And sometimes they are considered as separate condition. But classically, IgA nephropathy is associated with this type of vasculitis. Also, it's associated with alcoholic cirrhosis, associated with GIT disorders like celiac disease and inflammatory bowel disease. Also, it has been linked with skin disorders like psoriasis, dermatitis herpetiformis, and also it's linked with spondyloarthropathies. These are associations with IgA nephropathy, but it's always and usually idiopathic condition. Clinically, IgA nephropathy has a variable clinical presentation. It can present in different ways. The commonest presentation, is with asymptomatic microscopic hematuria. Remember, we said that one of the possible clinical presentation of glomerular disease is just by microscopic hematuria, not nephritic syndrome. Microscopic hematuria and asymptomatic. This is actually the commonest IgA nephropathy presentation. But the classical, not the commonest, the classical presentation, especially in the exams, you have a young adult presenting with recurrent episodes of gross or macroscopic hematuria which is visible on the naked eye. And this macroscopic hematuria is usually associated with an upper respiratory tract infection. It develops usually after 1 to 2 days or 1 to 3 days following an upper respiratory tract infection. So following an upper respiratory tract infection, after 1 to 2 days, the patient will start to develop gross or macroscopic hematuria, and it can be recurrent over the years, and it's usually seen in young adults. This is the classical presentation in IgA nephropathy, but this is not the commonest presentation. So IgA nephropathy can give you microscopic hematuria, and unusually, can give you macroscopic hematuria, and this is different than the other types of glomerulonephritis, because in glomerular injury, usually the presentation is with microscopic hematuria. But IgA nephropathy is unusual in the fact that it can present with macroscopic hematuria. But remember, it's always associated with upper respiratory tract infection. And it's very important to differentiate this association with upper respiratory tract infection from post-streptococcal glomerulonephritis, because in post-streptococcal glomerulonephritis, also the condition is preceded by upper respiratory tract infection. But the interval is longer in post-streptococcal glomerulonephritis. It can take weeks, it can take 1 to 2 weeks, or even up to 6 weeks. But in IgA nephropathy, the upper respiratory tract infection is developing at the same time of the hematuria. Hematuria will develop around 1 to 2 days following the onset of upper respiratory tract infection. So there is no interval between the onset of the infection and the development of hematuria. This is one way to differentiate between the two types of glomerulonephritis, diffuse proliferative and IgA nephropathy. There are other types of presentation. IgA nephropathy can present just with hypertension, with secondary hypertension. And hypertension, usually it reflects nephritic syndrome. Like here, the patient can just present with hypertension, and it indicates glomerular injury. As we know, secondary hypertension has a lot of causes, can be sometimes renal causes, can be endocrine causes. One of the possible renal causes of secondary hypertension is glomerular disease, and specifically IgA nephropathy. This is an important cause of secondary hypertension. Then another possible presentation in IgA nephropathy, it can present with nephritic syndrome. It can present with full picture of nephritic syndrome with all features of nephritic syndrome. Also, IgA nephropathy can present sometimes with proteinuria, and usually when there is proteinuria in IgA nephropathy, it tends to be mild proteinuria, yani below the nephrotic range, subnephrotic range proteinuria. But there are rare cases of IgA nephropathy which can present even with nephrotic syndrome. So as you can see, IgA nephropathy can give you everything, can give you all the types of clinical features that we talked about it previously. Can present in different ways. That's why the clinical presentation is variable. It can give you proteinuria, but usually tend to be mild, but sometimes in rare cases, it can be heavy proteinuria up to the extent of nephrotic syndrome. So since IgA nephropathy can cause nephritic syndrome and it can cause sometimes nephrotic syndrome, so that means this disease can give you acute kidney injury or it can give you chronic kidney disease. And even IgA nephropathy can sometimes present as rapidly progressive glomerulonephritis. And remember, rapidly progressive glomerulonephritis is an aggressive type of glomerulonephritis. So IgA nephropathy can present as rapidly progressive glomerulonephritis, and so it can lead to acute kidney injury. So IgA nephropathy can lead to acute kidney injury, and it sometimes can lead to chronic kidney disease. So the disease has different clinical behaviors between different patients. But it's important and common type of glomerulonephritis. So how to diagnose this condition? On biopsy, on renal biopsy, the characteristic morphological type of IgA nephropathy is called mesangial-proliferative glomerulonephritis because there is proliferation of the mesangium specifically. When you do light microscopic examination, you will have increased cellularity, and this hypercellularity is coming specifically from the mesangial cells, and these are the cells between the glomerular capillaries. So the mesangial cells will start proliferating, and it will produce more extracellular matrix material, and this will lead to mesangial expansion. So this mesangial expansion is characteristic in IgA nephropathy, and when you do electron microscopic examination, you will find immunological deposits trapped within the mesangium. And on immunofluorescence, these deposits will be consisting of IgA antibodies specifically. And this will give you the diagnosis of IgA nephropathy. So in IgA nephropathy, you will have an IgA containing immunological deposits within an expanded mesangium. This is the characteristic histological finding. As you can see here, there is proliferation and hypercellularity of the mesangium between the capillaries. These dark eosinophilic areas indicates hypercellularity of the mesangium. And this is the immunofluorescence staining showing IgA, but focus here, the hypercellularity of the mesangium, and this is characteristic in IgA nephropathy. So how to manage this condition? The management depends on the clinical scenario. As we said, IgA nephropathy can behave clinically in different ways. It can present with different clinical manifestations. So according to the type of clinical manifestations you are having, you will treat accordingly. First, let's talk about if you have nephritic presentation or hematuria, whatever the type of hematuria, microscopic hematuria or macroscopic hematuria or nephritic syndrome. In all these situations, you will just consider supportive treatment. You will not give specific treatment. And you will not give immunosuppressive therapy if the patient is presenting with nephritic manifestations or with hematuria. If the patient is presenting with hypertension, here you have to control the blood pressure. This is the essential part in the treatment. So control of hypertension is the essential part in the management of IgA nephropathy. If there is proteinuria, you will control the proteinuria by ACE inhibitor or ARB, whether this proteinuria is subnephrotic or nephrotic range proteinuria. Steroids and immunosuppressive therapy is indicated in two situations in IgA nephropathy. Number one, if you have nephrotic syndrome, which is rare. If you have a case of IgA nephropathy presenting as nephrotic syndrome, here you should give steroids. This is an indication for a steroid in IgA nephropathy. The second scenario, if you have a patient of IgA nephropathy presenting with rapidly progressive glomerulonephritis, which is also called crescentic glomerulonephritis. This type of glomerulonephritis is an aggressive type of glomerulonephritis, and whenever you find this type of glomerulonephritis, here you should give high dose of IV steroid, which is called pulse steroid therapy. pulse steroid therapy means that you will give high dose of IV steroid, like IV methylprednisolone, and you will give it in combination with cyclophosphamide, plus or minus plasmapheresis. Plasmapheresis or plasma exchange is indicated in certain types of rapidly progressive glomerulonephritis, but not in IgA nephropathy. In IgA nephropathy, when you have rapidly progressive glomerulonephritis secondary to IgA nephropathy, you will give pulse steroid therapy, IV methylprednisolone, in combination with cyclophosphamide only. So the only two situations in which immunosuppressive therapy and steroid are indicated in IgA nephropathy, if you have nephrotic syndrome, which is rare, or if you have rapidly progressive glomerulonephritis, in which you will give high doses of IV steroid in combination with cyclophosphamide. So these are the basic management of IgA nephropathy. So supportive treatment in case of nephritic syndrome and hematuria, control of hypertension if present, control of proteinuria if present, steroids in indicated cases. This is a comparison between IgA nephropathy and post-streptococcal glomerulonephritis because they have some similarities. As we said, usually there is weeks between the infection. It develops 1 to 2 weeks, like sometimes up to 6 weeks after an upper respiratory tract infection. While in IgA nephropathy, it develops 1 to 2 days after upper respiratory tract infection. IgA nephropathy is commonly seen in young males, but also post-streptococcal glomerulonephritis is common in young patients, in children. Here, the commonest presentation is microscopic hematuria. Here, the difference, here also can present with hematuria, as you can see, the shared features between the two are recent respiratory tract infection and hematuria. Both can give you hematuria. But here, sometimes you can have mixed nephrotic, as you said previously. And for that reason, proteinuria can be seen here. But again, in IgA nephropathy, in rare cases, it can present with proteinuria as well. In post-streptococcal glomerulonephritis, important way to differentiate from IgA nephropathy, here always you will have low complement. You have low C3, but here the complements are normal. So these are the basic differences between the two types of glomerulonephritis. The final type of glomerulonephritis that we will discuss is rapidly progressive glomerulonephritis. This is the most aggressive type of glomerulonephritis, and by definition, it's a term used to describe a rapid loss of renal function associated with the formation of epithelial crescents in the majority of the glomeruli. So to put a diagnosis of rapidly progressive glomerulonephritis, you need to have rapid loss of renal function, worsening of the renal function over days or over weeks, in combination with epithelial crescents on biopsy. So you need clinical features with histological findings to put the diagnosis of rapidly progressive glomerulonephritis, and it's also called crescentic glomerulonephritis because it's characterized by formation of epithelial crescents in the glomeruli. What happens in this type of glomerulonephritis, there is an extensive inflammation with extensive infiltration of the glomeruli with inflammatory cells, and these inflammatory cells will release some important inflammatory mediators of inflammation. And these mediators of inflammation can include cytokines, it can include some proteolytic enzymes, it can include some growth factors. And this heavy release of growth factors by the inflammatory cells will act on the parietal layer of the Bowman's capsule. As you can see, as we discussed previously, the basic structure of the glomerulus. This is the Bowman's capsule. The outer layer of the Bowman's capsule is called the parietal layer. This is the outer layer lining the Bowman's capsule. It's called the parietal layer. This is the layer which will be acted upon by the growth factors. The growth factors will stimulate these cells, and these cells will start proliferating in uncontrolled fashion, and they will proliferate inside the Bowman's space here, and it will start obliterating the Bowman's space. Normally, the Bowman's space, as you can see, normally it looks like a crescent. And when it becomes filled and obliterated by the epithelial cells here, the epithelial cells will take the shape of the Bowman's space, and it will give you a characteristic epithelial crescent occupying the Bowman's space. So the Bowman's space will be eventually obliterated by these epithelial cells. And since the Bowman's space is becoming obliterated by epithelial cells, you can understand that the GFR will be significantly reduced. And so the patient will have acute kidney injury that progresses and develops over a short period. And that's why it's called rapidly progressive glomerulonephritis. And on histological findings, you will have this characteristic epithelial crescent can be seen, this epithelial crescents, which can be seen clearly here. These are proliferating epithelial cells of the Bowman's capsule, parietal layer, occupying the Bowman's space, giving the characteristic crescent appearance. Here also can be seen. So what are the possible etiologies in rapidly progressive glomerulonephritis? Again, as with any types of glomerulonephritis, it can be idiopathic, it can be primary. But here there are important secondary causes that you should look for and you should exclude. Number one, it can be due to some types of small vessel vasculitis, specifically ANCA-associated vasculitis. There are different types of vasculitis, as we know, classified according to the size of the dominant size of the vessels affected. We have small vessel vasculitis, and specifically we have ANCA-associated vasculitis, classically associated with rapidly progressive glomerulonephritis. Example, we have granulomatosis with polyangiitis, previously known as Wegener's granulomatosis. We have also eosinophilic granulomatosis with polyangiitis, previously known as Sherb-Strauss syndrome. And we have microscopic polyangiitis. All these are ANCA-associated vasculitis. Here, the glomerulonephritis and vasculitis is not mediated by immune complexes. It's mediated by anti-neutrophil cytoplasmic antibodies, ANCA antibodies, and will be positive. We have C ANCA, we have P ANCA. So this is one of the possible causes or etiologies of rapidly progressive glomerulonephritis. Another possible etiology is antiglomerular basement membrane disease, which is known as Goodpasture syndrome. This is a disease in which it's an autoimmune disease in which there are autoantibodies directed against type 4 collagen, which is present in the alveolar basement membrane and in the glomerular basement membrane. This is an example of glomerulonephritis in which the antigen is fixed to the glomerular wall. The antigen is not free antigen in the blood, which has led to formation of immune complexes in the blood. Here, the antigen is within the basement membrane. It's a type 4 collagen. And this antigen, against which there are antibodies, will react. And this is an example of type 2 hypersensitivity reaction in which the antigen is fixed to the target tissues. And so in Goodpasture syndrome, the autoimmune disease will be associated with damage to the alveolar basement membrane and also injury to the glomerular basement membrane. So you will have glomerulonephritis, which tend to be rapidly progressive glomerulonephritis, crescentic glomerulonephritis, and clinically presenting as acute kidney injury. And at the same time, it can damage the alveolar membrane, basement membrane, and can lead to pulmonary hemorrhage. And the patient can present with dyspnea, can present with hemoptysis. So if you have a combination of renal with pulmonary manifestations, if you have bleeding from the lungs and bleeding from the kidney, hemoptysis, hematuria from glomerulonephritis, think of Goodpasture syndrome as a possible underlying condition. Another also etiology is lupus nephritis. As we know, lupus has different stages. And one of the possible presentation in lupus nephritis, it can present as rapidly progressive glomerulonephritis. As we said, lupus nephritis commonly present as diffuse proliferative. This is the commonest type of lupus nephritis. But remember, diffuse proliferative glomerulonephritis can convert into rapidly progressive glomerulonephritis. So lupus nephritis is one of the possible causes of rapidly progressive glomerulonephritis, as well as post-streptococcal or post-infectious glomerulonephritis, because here again, there is diffuse proliferative glomerulonephritis, and it can convert into rapidly progressive glomerulonephritis. And finally, IgA nephropathy, as we discussed previously, it has different clinical presentation. One way of presentation is with rapidly progressive glomerulonephritis. So clinically, patients with rapidly progressive glomerulonephritis, they will present with acute kidney injury. You will have complications associated with AKI. So your management depends on controlling and supportive therapy for AKI. You will control all the complications of AKI. You control the fluid overload. You control the acidosis. You try to control the electrolyte imbalances, hyperkalemia. We will not go into details of management of AKI, but basically, when you are talking about rapidly progressive glomerulonephritis, first you try to provide supportive therapy for AKI, and then the specific treatment for rapidly progressive glomerulonephritis, whatever the cause, is to give pulse steroid therapy high doses of IV steroid, IV methylprednisolone, in combination with cyclophosphamide IV, and plus or minus plasma exchange. Plasma exchange will be added to the treatment of rapidly progressive glomerulonephritis if it's secondary to ANCA-associated vasculitis or secondary to Goodpasture syndrome. And in these situations, you will add plasma exchange. But in other situations, you will treat only with the steroid and cyclophosphamide. So this is basically the management of rapidly progressive glomerulonephritis. We'll talk briefly about Goodpasture syndrome since it's an important cause of rapidly progressive glomerulonephritis. It's an autoimmune disease. It's rare. It's associated with both pulmonary hemorrhage and rapidly progressive glomerulonephritis because it attacks the alveolar basement membrane and the glomerular basement membrane, where type 4 collagen, against which the antibodies are reacting. It's more common in men. Antibodies, as we said, formed against type 4 collagen in the glomerular basement membrane and alveolar basement membrane. To diagnose the condition here in Goodpasture syndrome, you can do renal biopsy and you can also do lung biopsy. In renal biopsy, of course, you will have the crescentic type of glomerulonephritis with IgG deposits along the basement membrane, because the target here in this disease is in the basement membrane, type 4 collagen of the basement membrane. So the immunological deposits will be located within the basement membrane and it will be made of IgG antibodies. When you do lung biopsy, you will have accumulation of hemosiderin containing macrophages, hemosiderin-laden macrophages. The macrophages will engulf hemosiderin within the alveoli. And this indicates there is alveolar hemorrhage. Whenever there is alveolar hemorrhage, you will have hemosiderin inside the macrophages. This gives you a clue that there is pulmonary hemorrhage. But also, if there is pulmonary involvement in Goodpasture syndrome, you can do pulmonary function testing, and specifically, you will have increased KCO. You will have increased diffusion capacity for carbon monoxide. Increased KCO indicates pulmonary hemorrhage. The management, of course, as we said, we give pulse steroid therapy with IV methylprednisolone with cyclophosphamide, and you add plasma pheresis as well here in Goodpasture syndrome. So that's all for our discussion today. We tried to cover the main types of glomerulonephritis. I hope everything is clear. Anyone has any question?
It is very clear, Dr. Khalid.
Thank you.
And,
anyone has any question about this lecture or even the previous one?
I believe you cover everything. I would like to convey my appreciation for presenting this wonderful session.
Oh, you're welcome.
And I wish you all the best for your new course.
Thank you for having me with you and giving me the opportunity. I hope to meet you all, inshallah, the next session. We'll try to have a different talk about different topic other than nephrology.
Okay, great. والله it was really wonderful. حاجة جميلة جدا و you cover everything. بارك الله فيك.
شكرا جزيلا.
شكرا كثير دكتور خالد، جزاك الله خير. كانت سيشن جميلة وشافية وكافية وما شاء الله. الله يديك العافية دكتور خالد، جزاك الله خير.
شكرا لك، شكرا لحسن الاستماع والحضور.
الله يحفظك دكتور خالد، جزاك الله عننا كل خير يا أخي.
شكرا يا دكتور.
الله يسلمك بالعافية. شكرا لك.
جزاك الله عننا كل خير يا دكتور، جزاك الله عننا كل خير.
الله يسلمك، شكرا لكم. I'll see you next time إن شاء الله. السلام عليكم.
إن شاء الله. شكرا جزيلا.